Welcome to video 5. My name is Anna White. We will now shine a light on how to identify people who may be in pain and how this is often the cause of challenging behaviour. You are now watching video 5, Understanding, Managing and Preventing Pain. Remember, there are many learning disability services and websites there to support you. If you have any difficulty getting assistance, then please contact us and we will be here to help you. You will remember Dr. Karen Dodd, a consultant clinical psychologist and author and specialist in this area. And Diana Kerr, world-renowned expert on nighttime care and disability and dementia. So the bad news is, we know our services are not ready. So we need to be and be a part of transforming our nation into becoming informed and ready. The great news is that people with learning disabilities like us are living longer. Research has shown that the likelihood of when we grow older, we may experience more pain. In any 4-week period, 64 to 86% of older people will suffer with chronic pain. There is no reason why people with learning disabilities are any different. Research has shown that people with dementia are prescribed and given less pain relief than other older people. And even when pain relief is prescribed to a person with dementia, 83% did not receive their medication. One study showed that only 12% of people with dementia living in nursing homes got adequate pain relief. People were, however, getting a lot of sedation and antipsychotic medications. Diana, who does a lot of training in this field, has also found that there's a direct link between care team training and staffing levels and the prescription of sedation and antipsychotic medication. In other words, the more pressure on staff due to insufficient staffing levels meant the more the sedation medication was used. This was not linked to dementia. A study was raised concerning whether the experience of people in the general population may be being replicated for people with learning disabilities. People who were consulted as part of this research were direct care staff, doctors, psychiatrists, community nurses, psychologists, occupational therapists, and so on. What was noticeable was how rarely pain was mentioned, and it is possible that a person with learning disabilities may be in more pain due to their medical conditions. The information provided in this video have come from the findings of a research project called Responding to the Pain Experiences of People with a Learning Difficulty and Dementia, and may be found on the Books and DVDs tab of this website. Diagnostic overshadowing. This is when a diagnosis such as dementia causes all other illness, behaviours and conditions to be attributed to dementia as opposed to other causes. Let me explain. There is a presumption that a person with some challenging behaviour is doing so because they have a learning disability. Be aware this is not necessarily so. Is it because they have dementia or are in pain? Let me give you an example of diagnostic overshadowing taken from the research Responding to Pain I mentioned in the previous slide. Roger is a gentleman with Down syndrome and a diagnosis of dementia. He is described by his care team as being a determined man, used to getting his own way and not averse to being a bit awkward to achieve what he wants. He is seen as a man who presents challenges to others, has a number of health-related problems that could be causing him pain. His few teeth, the ones he does have, are in poor condition. They are wobbly and indeed have started to fall out. Recently, one was found on his pillow in the morning. The dentist said that he thought this might be causing him some discomfort. That's an understatement, I suppose. Roger often refuses to eat. The care team staff say every morning when they gave him breakfast, he says, "My head hurts." They agreed when Diana asked them that he might have painful gums. He also had very sore eyes, as he had blepharitis, which people with Down syndrome are prone to. The eyes are dry and they bleed in the corners, and he constantly rubs them. Sometimes he will poke them with objects which would appear to be an attempt to scratch them. In fact, on one occasion with a fork, which is perhaps some reflection of the level of pain in his desperate attempt to alleviate that pain. Roger also wakes at night, where he curses and swears. It's worth pointing out his home did not have night waking staff. They had sleeping night staff, and he had a little baby monitor in his room. The care team would say that he sometimes bangs his head on the wall of his bedroom and wakes up the other service users or residents. Staff said to Diana his sleep disturbance is one of the things we struggle with most. In fact, the care team staff stated to Diana that Roger's nighttime disturbance was, in their view, related to the impact of his dementia. And this is where training is needed. So the assumption is that waking at night is related to dementia, rather than the pain from his teeth. This is what is called diagnostic overshadowing. The presumption is that it is the condition of dementia rather than the fact that he was in pain. One condition overshadows the other incorrectly, as you can see. So because of this, waking at night incorrectly diagnosed as due to the dementia meant that the care home manager would consider moving Roger to another home where there were waking night staff. And instead, what Roger needed was a visit to the dentist with a proper review of his dental condition and then regularly administered and monitored pain relief. Moving people should be a last resort, and we will talk more about that later in this video. Again, research has shown how people with learning disabilities more often present with behaviour that challenges their carers and services than their non-disabled, age-matched peers. Training is needed, like this course, to enable people to be tuned in to understand challenging behaviour better. We need to reconsider our responses when someone has dementia. Are they actually in pain? Let me tell you about a lady whom Diana met when doing her research. We will call her Jane for the purposes of this narrative. In the mornings, Jane shouted abuse and hit out at the care team when they tried to help her out of bed and then go to the bathroom. There was some feeling that she did not want to get out of bed and face the day. In fact, it was seen as that well-known behaviour, being stubborn. This seemed to be confirmed by the fact that the screaming and hitting stopped after the bath was done and the day progressed. The morning routine was becoming increasingly distressful for everyone concerned. Diana saw lots of examples of the assumptions by carers that he or she is in bed because they can't be bothered to get up. Often the care team would comment that they would dread getting people up in the mornings, but that the behaviour improved as the day progressed. All of these people, Diana found, had arthritis. Do you have arthritis or know anyone that does? If not, let me explain. In the morning, arthritis is really painful and it puts the whole body in pain. It's like it has seized up. Moving is very, very painful, and people like Jane, who has Down syndrome, are very susceptible to arthritis, even from as early as in their 40s. When Diana spoke to people in the general population who had dementia, the thing they mentioned most often was arthritis. They would say, I have this pain here and I have this pain there, and point to different areas of the body. There was one lady, Judy, who said, bearing in mind her mum had arthritis, I know what to do. I get up at night and I press my foot down hard till the pain has gone away. When Diana asked the care team if they thought, do you think Jane has pain? They said no, they don't think so. She seems to sleep through the night. This poor lady needed pain relief. A lot of people said they had lumpy mattresses, and actually what they were saying was they had pain. If you have a pain in your hip or knee, it can feel like a lump, and so you move off of the lump, and that is in order to move off of the pain. So their response was to give Jane paracetamol to determine if she improved and monitor it, and she did. We need to monitor pain. This can be done with the Abbey scale assessment tool. Most care teams say they have little time to fill in lengthy forms. The Abbey scale pain assessment tool is 1 page, very short, highly usable, and it takes only 4 minutes to do. I have provided a link to it on the books and DVDs of this website so that you can get a copy. This monitoring of pain needs to be done, and then each morning, in Jane's case, by each care team member who helps her to determine if it is sufficient and effective. Remember that people with learning disabilities will have communication difficulties. A baby, as it grows, learns where they start and end by touching and reaching out. Someone with dementia means their brain cannot tell them where the pain is anymore, as the brain has become damaged and can no longer relate to the geography of the body. People may make sounds or groan, and Diana would often find care team members would say in response to someone groaning, "Oh, she has dementia." Remember that dementia involves the loss of previous levels of verbal skills. The person will highly likely no longer be able to find the word toothache. This is because there is a loss of the sense of the geography of the body. They can no longer locate the toothache. They will use generalized words such as head hurts, or use substitute phrases such as "oh dear, oh dear, oh dear." Well-remembered words such as tummy ache may be remembered but may not represent where the location of the pain is. Remember, rollback memory plays a part here. They may use the abstract tummy ache to describe "I'm in pain," "I can't find it, but I do have it." As diaries go back in the rollback memory, what is happening when they express pain is they are doing so in the way they used to when they were younger, and this is what is now being demonstrated. Often this is misunderstood as challenging behaviour, or he or she is up to their old ways. The belief that people with learning disabilities have high pain thresholds persists. There is no evidence to support this. Diana speaks of a gentleman we shall call Keith, a man with Down syndrome with a diagnosis of dementia in his early 50s. He has a severe back problem and is often seen shaking and unable to walk because he is in so much pain from the back spasms. However, when asked, "Keith, is your back hurting?" he says, "No, I'm all right," even though he can barely walk. He is also reported to have sometimes diarrhea and vomiting, and the care team said to us that he would be vomiting into a bucket and he would still be telling the care team that he is fine and there is nothing wrong with him. There are many examples of this in the study. There was one lady whom the care team said must have had a very high threshold of pain because they found a drawing pin in her foot and the skin had grown over it. This is where the care team just did not pick up the pain signals. This must not be allowed to happen. There are a number of reasons why people with learning disabilities choose not to reveal their pain. A lot of people who are in their 60s now have spent most of their lives in institutions and have learnt that complaining of pain actually does not make any difference, or hasn't in the past, and if they did complain, the response was out of all proportion to the pain they expressed. There is a tragic example of one man who said he had a toothache as a young adult. This was back in the 1950s. And so for some reason the decision was made to take out all his teeth. This happened in the past with people with learning disabilities, but we can change this, and this is up to us to do. It's all about better training. So let's press on. Here is a poster that was created specifically for doctors' offices and for care homes. I've put a link on the books and DVDs tab of this website so you can access it. Get a copy and take it the next time you go to your doctor's office. Tell them to put it on the wall and give them the link to this website. Staff in care homes and family members are not trained to look out for conditions of older people in a young 40-year-old person, for example. When one compared staff working in general population care homes with older folks, they may well consider such things as osteoporosis, arthritis, dementia by virtue of the age of the people they are working with. For example, people with Down syndrome have smaller ear canals and so likely to suffer from impacted ears as they do not normally have back molars, and it is the action of chewing and having back molars that keeps the ears clear. Many people with learning disabilities don't have many teeth and so likely to have impacted ears, and this is very painful. In a study in a big city in the United Kingdom, it was found that 74% of people with learning disabilities had impacted ears and were untreated. This is where we come in. We need to look out for these conditions and the pain behaviour. The doctor relies on what the care team staff or family members have to say for the person who has learning disabilities. So we have to be alert, know what to look for, and then tell the doctor. Doctors all over the country have told me they just do not have enough training in this area, and we need to help them as well. Did you know, for example, that a person with Down syndrome can especially suffer from back pain? This is because they have short legs, so they do not have any support when sitting in a normal chair for their feet. All that is required is a small footstool or child step to be put under their feet so that their body can be suitably supported and so they do not get back pain. We can all do this. This is simple stuff. I am sure you will be aware of the expression PRN. PRN is a shortened form of the Latin phrase pro re nata, which translates roughly as is needed. If people with learning disabilities have difficulty expressing to us pain or rely on our identifying if they are in pain, then pain relief as required is not appropriate. Hence why 86% of people are not getting pain relief, because we are not identifying the challenging behaviour as actually that the person needs pain relief. PRN, or pain relief as required, should not be the primary approach to pain relief for people with dementia. Here is an example from the study that Diana did. A lady was given pain relief ad hoc during the day or at 6 p.m, but then nothing for when she goes to bed. Yet it was known she has pain all day and all night. If it is not being given regularly, then it gets missed, and the person wakes up at night in pain. The odd thing is, and maybe this is just a human trait, but people seem reluctant to administer pain relief unless specifically and directly asked. Diana found that the care team staff did not seem to have problems giving sedation or antipsychotic medication, but did have a problem administering pain medication. They would say, "Oh, they might get addicted," and that was a common phrase. WHO guidelines say that PRN is not the primary response for people in pain, but rather regular administration, which is then properly monitored, is best practice. So, our key recommendations and learnings are: all care team staff and families require training on the impact of dementia, like this course. Raise awareness of pain as a possible explanation for the changes in the person's behaviour. Challenge our response to challenging behaviour. As required pain relief should not be primary response. Use non-pharmaceutical interventions for prevention of pain. Consider also pain management with heat and music, and we will be looking more at this in later videos. Get some of these pain posters and take them to your local doctor's office. Help us get the message out there. So far, we have questioned whether challenging behaviour is inadvertently being caused by carers. Roll back memory, how the expression of that pain plays a part. Could pain be the cause of challenging behaviour? The importance of a baseline assessment. The creation of a picture life book, and the use of the Abbey's pain scale and the proper administration of pain relief. 3 key pieces of information I want you to take away. Is the behaviour that you are noticing actually pain behaviour? Remember, the ability of the person to locate the pain becomes increasingly difficult as their brain is increasingly unable to work out the geography of the body. They know they have pain but are unable to articulate where. This website has a link to the Abbey Scale pain assessment tool. Please use it. Remember, best practice guidelines for pain relief is to administer regularly with the agreement of your doctor and not PRN. This has been a long training module, I know, and thank you for hanging in there and keeping with it. This topic is so important and deserved the extra time. Look forward to seeing you in video 6, Environment Management, and all about the space we live in. Thank you.